we're going to talk about the three different types of cannabis because it gets so confusing in the literature. You'll hear people cite data about the efficacy of cannabis.
So we do require
And unfortunately, they are maybe talking
Right.
about some of the scientific studies that have been done with FDA approved products, or another study may be related to the phytocannabinoids. So I want to define all of that so we're all coming from the same perspective. We're going to talk about the different routes of administration and what we know about taking cannabis from different etiologies, like taking it inhaled, edible, topical, etc. And then we're going to talk about two potential risks of cannabis use. Now, you are undergoing treatment for cancer and you ask your doctors if you should try cannabis for symptom control. So here are some of the answers that you might receive. No, you have cancer. Or yes, and I highly recommend Wowie Maui or Purple Kush or one of the other different varieties. Or the best answer, if you were to ask your doctor or your advanced practice nurse, tell me about the symptoms that you're experiencing and your goals for treatment. Maybe we just haven't thoroughly addressed the pain, the nausea, the sleeplessness, etc. And possibly there are other medications that might be a little bit safer. So I wanted to just spend a minute telling you a little bit about some of the historical perspectives. I always find it fascinating. You know, we think everything is invented today. And in fact, cannabis in particular has been around for 5,000 plus years. It probably began somewhere in Central Asia and it spread likely through the Silk Road to China, India, Persia, Egypt, and Syria. And it was widely used medicinally, recreationally, and spiritually. But our more modern understanding of cannabis came in the 1830s when an Irish physician began working in Calcutta and he wrote a paper called Indian Hemp. And what he was advocating cannabis to be used for was pain, vomiting, convulsions, spasticity, and not so different than what we see today. So I'm going to ask everyone to mute their mics. Thank you. All right. And believe it or not, in the mid 1800s, cannabis was listed on the US dispensatory. In other words, the US list of medications that were useful for treatment of medical conditions. And then in the late 1800s, we saw cannabis being used quite a bit as tinctures, as extracts, as plasters, and in cigarettes. And what was it being used for in that time? Insomnia, headaches, anorexia, sexual dysfunction, pain, whooping cough, asthma. So for quite a few different treatments, not so different than what people have advocated for today. Now, it does get a bit confusing because there are different strains of cannabis. So you may have heard about cannabis sativa, cannabis indica, and cannabis ruderalis. The most common are sativa and indica. Hemp is a member of the sativa family, and hemp is legal. In fact, if you have any ropes at home or some plastics, they include or are made of hemp. And that is legal because hemp has very little THC. THC stands for delta 9 tetrahydrocannabinol, and that is the active ingredient of cannabis that causes the more cognitive changes. And this is the substance that is a Schedule 1 controlled substance by the US DEA. And it therefore is in the same category as heroin and PCP and other substances. So it's the THC part that is illegal, if you will, in the United States. And it's hemp is legal because it has very little THC in it. Some of this is done because of legislation to allow truckers to cross state lines carrying hemp. Hemp isn't used very much medicinally. So the sativa, indica, and ruderalis has a higher THC content. So let's get right to our first objective. What are the three types of cannabinoids? Well, there's cannabis, which is the phytocannabinoids. And that is what you see dispensed that looks like plant content in the dispensaries. They may have processed it to some degree and are giving it out as maybe as a cigarette, maybe as an edible, maybe as an oil. There are cannabis-based medicines that have actually undergone testing, and some are approved by the FDA. Some are approved by the FDA equivalent in other countries. So Marinol, you may have heard of this. Some of you may have actually been prescribed Marinol. It is the generic called dronabinol. Marinol is the trade name. It's actually quite an old agent, originally released for chemotherapy-induced nausea. But we've had so many better antiemetics developed since this agent was released that now it is only approved for HIV-associated anorexia. So I will use it for some of my patients. We'll try it to see if it helps with nausea, it helps with appetite. It is a devil to get approved by different insurance companies, again, because it's only approved in HIV/AIDS. It is an old drug, but unfortunately, it's still an expensive agent, so I'm not quite clear why that's the case. Where I typically will use Marinol is if someone is a recreational user of cannabis and they use it quite commonly or frequently, and now they're coming into the hospital for an extended period of time, maybe having a stem cell transplant, we might use Marinol to help prevent withdrawal. And we're going to come back to withdrawal. It can occur when someone uses cannabis regularly. Sizamet is an old anti-nausea medicine. It's no longer used in the United States anymore, and it was for cancer-related nausea. Sativex is a spray used in the mouth. It was tested extensively in the United States. It was approved in Canada and quite a few other countries in the EU, but it has never been approved in the United States. It was originally approved in Canada for spasticity associated with multiple sclerosis. But those patients started reporting that it was also helpful for their nerve pain. And that's what led investigators to study it. Now, the data are kind of mixed. Some say, yes, it does help nerve pain. Others haven't been so conclusive. And then the last cannabis-based medicine approved by the FDA is called cannabidiol, or the brand name is Epidiolex. And this has been approved for children who have intractable seizures, particularly a specific kind of seizures. So those are the first two types of cannabinoids. The third is your body's own endocannabinoid system. Some of you may have heard of endorphins, your body's own endogenous or made in the body opioid. Well, there are also cannabinoids made by your own body. And there are different enzymes and products that can boost your body's own system. So this is the phytocannabinoids. This is what you typically see. Now, what do they contain? They've got lots of THC, lots of CBD, cannabidiol, which, by the way, CBD in its pure form is legal. You don't even need a card. You don't need anything because it is not a Schedule I narcotic. It is approved for use across the United States. Cannabinol, CBN, is another product. Terpenes are also found in phytocannabinoids, and lots of different other products or compounds similar to the cannabinoids that are found. These are dirty products, right? They're plant products, so they're going to have a lot of different agents within them. Now, those cannabis-based medicines that I mentioned, we pretty much already went over them. Here are some photos of the different products. THC, dronabinol, is still available in the US. Nabilone or Sesamet no longer available. Nabiximol has never been approved. And then Epidiolex is only for these severe pediatric seizure disorders. Now, these endocannabinoids, that third group, the one agent we know that is one of our own cannabinoids, endogenous cannabinoids, is anandamide. And if you look at the chemical structure on the left, it looks a lot like the chemical structure on the right of THC. So this is what led some investigators to explore more carefully what are the body's own endocannabinoids and where are they found? Well, they're found in the frontal cortex, which is the part of our brain that is responsible for pleasure and pain. Makes sense. Some people report euphoria when they use cannabinoids. Some report some pain control. Movement is mediated by the basal ganglia and the cerebellum, areas in the back of the brain, back here. Well, then that kind of makes sense too. Many people have reported that the cannabinoids help with spasticity. And then here's the downside, if you will, memory. This is a beautiful part of the brain called the hippocampus. And this is what's responsible for retaining information. And unfortunately, particularly in very young people, there's a decrease in the ability to retain new information. And so this is where some people are very concerned about cannabinoids being used in the very young. Now, again, this third group, the endocannabinoids, modulate our body's own endocannabinoid system. And here's one of the fun ones. It's called fatty acid amide hydrolase, or FA. Now, how do we find out about this? Well, there was an interesting story, and some of you may have read about this because it was widely described in the media, including the New York Times. So there was this woman who at 71 reported that she never felt pain, nor did she feel anxiety. She had kids, never felt pain, thought all her friends were just a bunch of crybabies about labor and delivery. She had several surgeries and broken bones, didn't understand why people were so upset about, the incisional pain. She also reported no anxiety. Now, here's something interesting. She also was described mostly by her family as being forgetful, losing items. Train of thought mid-sentence would be lost. She also never felt that adrenaline rush that all of us feel when we're under a lot of stress. And when she was characterized by some clever scientists, they found elevated levels of anandamide, her body's own endogenous cannabinoids, and that's normally degraded by an enzyme called FA. It turns out she didn't have this enzyme, and that's why they believe she had some of these attributes. And so that gives more information for why or how the body's own endocannabinoids work. Now, there is also a substance that many people are purchasing on eBay and Amazon called PEA, palmitoyl ethanolamide, or P, and it is an endocannabinoid. It's also a natural part of egg yolk, soybeans, peanuts, and milk. In Europe, it's marketed as an anti-inflammatory. The daily dose, in case people are interested, seems to range. We don't have any really good randomized controlled studies, but it ranges from somewhere between 300 to 1,200 milligrams daily for this anti-inflammatory effect. And you can see there are now some papers about this agent this was the British Journal of Clinical Pharmacology. So some people are looking at PEA as an agent that might help with inflammation. So those are the three types of cannabinoids. What about the routes of administration? We spend a lot of time talking about this in the clinic when working with patients who are really interested in the cannabinoids. So the first route is inhaled, and that can be either smoked or vaped. Now, when we talk about inhaled, most people who have cancer say, oh my goodness, I don't want anything inhaled. I want to protect my lungs. I have cancer. I don't want to hurt my lungs anymore. And yes, that is definitely true. There are some things you can use to mitigate the harshness. It would be like a nebulizer that would reduce some of the particulates that would be inhaled into the lungs. With vaping, one has to be so careful. You may remember there were some individuals who were making their own cannabis vapes in their bathroom or kitchen or something like that. And they were um, putting the cannabis in an oil, in vitamin E oil. And unfortunately, oils should not be introduced into the lungs. And several patients ended up on ventilators and some died as a result. So one has to be very careful about their source if they are using vaped agents. And we're going to come back to the differences between these three routes in just a second. So there's inhaled, there's ingested. And many people feel that maybe ingesting is somewhat safer, but there's some caveats to that. And then there are the topicals or the oils. And, those have really not been studied. Some people apply them to the skin and some people will ingest them. So what do we know about this? With inhaled, you get a high, quick bioavailability within minutes. And it's a pretty rapid and predictable onset, about 3 to 5 minutes. So it's easy to titrate, as we call it. In other words, you can take a couple puffs, and if you're looking for anti-anxiety effects or for sleep, you're done. You don't have to keep smoking. A few puffs may be enough, and you find out right away. Now, most users will experience mild euphoria, some relaxation, even alterations in perceptions, like colors may seem very rich or sounds may seem more deep. It intensifies ordinary experiences. And I'm including the picture of Mickey Mouse in Fantasia because, yes, I grew up in the 70s, and a very common activity for teenagers was to go to the midnight showing of Fantasia. Now, I can assure you they weren't little kids who were going to watch this Disney show at midnight on Saturday nights. And yes, the theater had a real predictable smell to it. Now, the careful thing that you need to be cautious about is that some people will actually feel dysphoria, more frightened, more anxious, and a bit paranoid. Some of that is likely related to the environment. So if you are in a comfortable, relaxed environment, you're less likely to experience this. But if someone is already highly anxious, they may have an opposite effect. Now, ingested seems safer, right? However, it has a very slow and unpredictable onset, whereas you get serum levels with inhaled in 2 to 5 minutes. With ingested, it's anywhere between 2 to 5 hours. And the ingestion is altered depending upon what's in your stomach. So versus, a full stomach versus an empty stomach, a very fatty meal may alter the absorption rate. So it's really quite difficult to predict how each person is going to respond to the different products and how the different products are formulated. So this little graph, which appeared in the Cancer Journal for clinicians, just demonstrates with oral, your serum levels are 1 to 6 hours, with inhaled 2 to 10 minutes. Now, topicals, we have no idea. If you're rubbing this on the skin, we have no sense of the absorption. Does it occur in minutes, in hours? Does it even get absorbed through the skin? Our epidermis and dermis and fatty layers are there to protect us from pathogens, and they do a pretty good job. So many drugs are not absorbed through the skin. So what are the indications? Who might benefit from cannabis? Well, if you just Google this, you're going to get a million different diagnoses. So let's really focus on those that we see in the cancer world. So you may have heard initially that glaucoma, and this was an argument for the legalization of cannabis way back decades ago. Well, it does seem to help reduce that intraocular pressure. However, we now have much better agents that are specific for glaucoma. What about nausea? Well, I've mentioned that it was originally used for treating chemotherapy-induced nausea and vomiting, but quite frankly, we have agents like ondansetron and prochlorperazine and others, which for most people are more effective. And we have now begun to see something called hyperemesis syndrome in people who are using cannabis. And it's quite identified in the emergency department, where someone may come in and report that they're having just all of this vomiting and they can't stop. The only thing that seems to stop their vomiting is a warm shower or bath. And that's sort of a classic picture of cannabis-induced hyperemesis syndrome. I mentioned AIDS-associated anorexia and wasting. The data are pretty inconclusive. For chronic pain, there are some models in animals. There are some studies in humans that suggest that cannabis may be of benefit. But again, a lot of conflicting data. Inflammation, and this is where a lot of people are very excited, because it does seem that cannabis, our body's own endogenous cannabis, as well as the externally applied cannabis products, may inhibit inflammation, which is a good thing for autoimmune disorders like rheumatoid arthritis, Crohn's disease, and in the laboratory, in the cells, it does seem to inhibit cell proliferation, which has led a lot of people to be excited about its role in preventing cancer. However, we're not even close at this point to say that cannabis is an anti-cancer agent. I mentioned multiple sclerosis and the use of the agent called nabiximols to help reduce spasticity and possibly the neuropathic pain seen in multiple sclerosis, and then the animal studies that we use, that we have about the seizures in children. So this is already a bit of an older study from 2014, but it was published in the New England Journal by Nora Volkow, who is still the head of the National Institute of Drug Addiction. And these data still hold up. You know, some people argue that cannabinoids are going to cause dependence, just like other substances, and it does. But if you look at the prevalence, it's a whole lot less than nicotine, much less than heroin, alcohol, and cocaine. So that leads many people to report that it's a more safe agent to use, but you still have almost 1 in 10 people becoming dependent upon the substance. And there is a withdrawal phenomenon, just like if someone is on opioids consistently, they will go through withdrawal if they stop it abruptly. If they are on alcohol consistently in high amounts and they stop it abruptly, they will experience withdrawal. Same thing with benzodiazepines, agents like lorazepam, alprazolam, and others. If you use it consistently and then you stop it abruptly, you will experience a withdrawal phenomenon. Well, the withdrawal phenomenon for cannabis includes irritability, anxiety, anorexia, weight loss, restlessness, and craving. Now, this table highlights some of the short-term concerns about cannabis and the longer-term concerns. So the short-term, it can impair short-term memory. So not so big a deal for many of us, but for school-age people, people in high school and college, that could be a significant impairment. We do worry about driving and coordination while driving, and the standard tests used by the police are probably not real accurate. Those were developed for alcohol, a different kind of coordination issue. It may alter judgment for some people. And then in high doses, paranoia and psychosis. So that's short-term use, likely in higher doses. What about long-term or heavy use? Yes, I mentioned where people will become dependent, and that seems to be higher in people who begin heavy use in adolescence or in people who are daily heavy users. It may alter brain development, difficult to know, poor educational outcomes, but a strong caveat to that statement. Are the folks who are using cannabis in school people who are already struggling with performance in school and are frustrated and so they turn to other substances? Or was it the substance that caused them to have challenges in school? Question that's really important and we don't know the answer. Cognitive impairment, those lower IQ with frequent users, but again, the same argument, chicken and egg, which came first. Diminished life satisfaction, same thing. Symptoms of chronic bronchitis, yes, particularly with a lot of inhaling. And this may mask other serious mental illnesses like schizophrenia or psychosis. Now, an interesting study that was done in 2018 looked at Colorado, Oregon, and Washington. And those were states that had recently relaxed any of the rules related to cannabis for recreational use. And these investigators looked at motor vehicle accidents and compared them to similar states in terms of the topography. So, so things like states like Nebraska, Utah, Wyoming, Idaho, and Montana. So rural states with some hills, some flatlands, somewhat comparable to Colorado, but cannabis at that time was not legal in those states. And what we saw was after relaxation of the rules in Colorado, Washington, and Oregon, there was a slight increase in the prevalence of motor vehicle accidents compared with states that did not have legalization. Okay, let's see. Now, another piece to be very concerned about, or to be cautious of, I would say, is that for those of you who maybe have a few little gray hairs, just like me, who maybe grew up at a time when cannabis was used as, a very common agent, the THC potency of what was used in the 70s is very different than what is being used now. So what's being grown and developed is got much higher levels of THC. So although some may have had experiences with cannabis as a youth, it's a very different agent, or as we like to say, it's not your grandma's THC. There's another phenomenon I just wanted to make you aware of, and that is where individuals are manufacturing a concentrate of cannabis that looks almost like honey or brittle. It's called dabbing, where people will take the plant material out of the formulation. They use a bunch of different products to do this, to extract the THC. They call it wax, shatter, or butter, and a bunch of other names. They'll often smoke this with glass pipes. And it kind of looks like these substances that you see here on the slide. So what about our interest, which is medical marijuana use in oncology? So this is a review that's just a few years old. And the authors basically concluded that it may have potential use as an anti-nausea medicine for refractory cancer pain, and maybe as an anti-tumor agent in the future. However, much of the existing data are based on small trials, animal data, or are outdated. So we really need some more information. Here was a study that was conducted interestingly in Israel. Israel has done a lot of the studies, has conducted a lot of the studies related to cannabis in different groups of patients. This one I pulled out because it was specific to cancer. Now, they tend to be pretty positive. These were a large group of patients, almost 3,000 cancer patients treated with medical cannabis between 2015 and 2017. The average age, as you would anticipate from a population of people with cancer, was around 60 years old, and about 54% were women. Almost a little more than 25% or a quarter of the patients had had previous experience with cannabis. The usual types of cancer: breast, lung, pancreas, colorectal, with a little over half of the patients with stage 4 disease, so more advanced disease. And most people were looking for sleep problems, pain relief, nausea, lack of appetite. And what they found was that most patients reported an improvement in their condition, an overwhelming number of patients, 95.9%. About 3% said no change, and about 0.3% felt a deterioration. So these authors concluded that this would be a reasonable therapy that we should try in people with cancer. Another group, the International Association for the Study of Pain, now they were focusing specifically on cannabis for pain, looked at all the literature, animal literature, low back pain literature, cancer pain, pediatric, adult, and they found that much of the existing literature has really significant gaps. A lot of the studies were not high quality. They had small numbers of patients. They didn't follow patients for very significant periods of time. They didn't have a control group. And that's really been a challenge for some of my colleagues who have been conducting some of these studies. People who already have used cannabis in the past know, if they're in the placebo group, they know, hey, this isn't cannabis. So then it's not an accurate trial because it's not a real placebo. They know that it's not the right drug. So those are some of the challenges. So this group basically concluded that we need a whole lot more data, good studies, and they really could not endorse or refute the use of cannabis. Now, another group from the United Kingdom that's really highly regarded related to pain, from Leeds, this group looked at a large number of clinical trials, and they found that there were really just a few that were specific to people with cancer. And in their review of this existing literature, they found that there was no difference between cannabinoids and placebo related to pain control in most of these studies. The cannabis did have a higher risk of adverse effects when compared with placebo, especially dizziness and sleepiness. And dropouts were pretty high, which means that either people got sick or people just didn't like the drug, and so they stopped using it. So these authors concluded that the addition of cannabinoids to an opioid-based regimen in people with cancer really was not particularly helpful. So I thought I'd share with you, I've given you a bit of information about the different kinds of cannabinoids, the different routes of administration, and a little bit about what we know about long-term use and some of the data. Let's talk about the regulatory issues, because they really are pretty significant in relationship to these agents. So these maps, I try to get them updated on a regular basis. So you can see the states with the dark green is where cannabis is legal for adult recreational use. In the light green, it's legal for medical use only. So Illinois is green, it's legal for medical and recreational. The orange states have no program for legal THC, either medicinal or recreational. And then there were a couple states, South Dakota, for example, where it's pending. So you can see about 2/3 of the states have some sort of legislation related to cannabis for either recreational or medicinal. Now, something that's really important to know is that there is no federal oversight of the content that you're buying from the dispensaries or from online sources. The DEA is only really looking at, do these dispensaries have appropriate licensing? The FDA is not looking at each of these products and determining, well, if it says CBD 1,000 milligrams on the label, the FDA isn't endorsing that. They don't have chemistry sets that they're using to evaluate those tablets that say CBD. So that's where I get so frustrated when I'm trying to help patients. They'll say, but it says 1,000 milligrams of CBD. Yeah, it says that. And nobody can really endorse that. Nobody is really looking to confirm that. And now I'm just going to say that your multivitamins and all the other herbal products that you buy are in the same situation. The FDA only evaluates the drugs that are approved for medical use by the FDA. The FDA will look at herbals, multivitamins, things like cannabis, if the sellers are making claims about cures. The sellers can say that it relieves a symptom, but the sellers cannot say that it will cure cancer, for example, or cure heart disease. That's when the FDA gets involved and will stop that kind of marketing. Now, in Illinois, I wanted to share with you specifically, the Illinois compassionate use of medical cannabis became a law in January of 2014. And I distinctly remember the long lines of people calling us to ask about this because the dispensaries weren't open yet. This was just the law was approved. Now, this was initially a pilot. It is no longer a pilot. It is fully enacted within our legal system in Illinois. Now, when you decide you would like to get a medical card, you need to go to your physician, and the physician is not prescribing cannabis for you. We can't prescribe it. It's illegal federally. It is only legal in Illinois and in other states, but what we are doing is signing for you or certifying that you have one of the many diseases that are listed in this legislation. And of course, cancer is one of them, as is ALS and HIV and quite a few other debilitating illnesses. And in fact, even chronic pain that's not cancer oriented is now listed as one of these debilitating conditions. Now, initially, the physician was supposed to endorse that the patient was going to get benefit from this medical use of cannabis. And a lot of physicians pushed back. They wouldn't sign these forms because they'd say, I can't say that the patient is going to get benefit from this. And so that piece of the legislation was taken out. So right now, only thing that the physician is signing is that they're certifying that you have one of these debilitating conditions and that you are under that physician's care. Now, more recently, the state is allowing APPs, in other words, nurse practitioners and physician's assistants, to sign these forms. However, many institutions are not allowing them. So the state allows it, but the institution does not. So for example, in Northwestern, I am an advanced practice nurse. I'm not allowed at this point to certify. Only MDs can certify through Northwestern. And this is all done now online. It used to be paper, so it's all done. Now, if your physician will not sign, what many dispensaries will do is refer you to a physician. You will need to see that physician twice because they are supposed to have an established relationship with you. And that's the way they get around that established relationship. For people who are on opioids, and I wouldn't imagine this would really be helpful for people with cancer, but I just wanted to mention that there is this program called an opioid alternative program. So you basically can turn in your opioids and get cannabis instead. That's probably not something that people with cancer would want to consider. Now, this is data that's just about a year old. I couldn't quite get the newest data, but you can see this is a growing business. So in the so their numbers of licensed medical dispensaries have increased by 185 during 2021. The total retail sales in 2021 were $97 million. This is just Illinois, by the way. The total retail sales since November of 2015, which is when most of the dispensaries actually opened, or at least the beginning dispensaries opened, quite a large number there, almost 1 billion. And the approved applications since 2014 surpass 154,000. So you can see it's a growing business, and Illinois got some financial issues. So you can see what might be motivating some of the feelings of allowing cannabis within our state. I do also want to mention that, and I'm seeing this in some of my patients, that the emergency department is seeing increased rates of cannabis-related admissions. So this was a study that was conducted in Colorado, one of the first states to allow recreational use. And what they found was that ED admissions were increasing related to cannabis. Probably, let's see, they felt that about 9% were related to edibles. And those people who were having hyperemesis syndrome, it was more related to the inhaled. I just wanted just to mention this. I have had a couple of my patients end up in the emergency room. They tended to be people who were a little bit older, and they would take the edible and they would not taste or not feel anything after they ate that, brownie or candy or gummy. And so they took another, and they still weren't feeling anything, and they took another. And that's where people started to have some difficulties. Because remember, it takes 2 to 5 hours with edibles to get that therapeutic level. And so as a result, if you keep tasting that gummy, you're going to run into trouble. I wanted to just share this resource with you because it's pretty new. It's within the last 6 months. Pennsylvania State put together this website where you can look at drug and herbal interactions with THC and CBD. So if you are interested in this, it's a nice resource to help people. So what are you really getting? There was a study, it's already a little bit old, where some investigators obtained cannabis products over the internet and in different dispensaries. And then these were chemists who then analyzed the substances, and they found accurate labeling in the dispensaries at less than 17%. And much of the CBD that was purchased over the internet contained little or no active ingredient. So I think the important message is don't buy this over the internet. So what are the bottom line? What's important for those of us who might have cancer, those of us who are helping people who have cancer? The pros are that there are possible health benefits, anxiety relief, sleep benefits, pain, reduction in spasticity. And for some people, there's a reduction in the opioid use. I will say that I follow about 200 people with cancer-related pain, and I have about 2 people who are able to get off opioids with the use of cannabis. So it's not an overwhelmingly large percentage of people. The cons of cannabis use: medical may give people that sense that there's not any risk, especially amongst younger users. So we need to be careful about that. We worry about access to people getting who don't have cancer or don't have a debilitating disease. This is how some people report that the opioid epidemic started, is people were getting access to opioid pills that were prescribed for people. Increases in impaired driving, although I just have to say, as an editorial statement, I wonder how much is really related to cannabis versus texting, but that's a whole nother soapbox. And then for children and pets, the edible forms are being mistaken, and we are seeing increased rates of kids and animals ending up in the emergency department because of accidental ingestion. So what does this mean for you? Talk with your oncology team about the symptoms that you're experiencing that aren't being managed and your goals of treatment. For those people who really need clarity in their thinking, who maybe are doing, precise measurements, precise mathematics, who really value their clear cognition, this may not be the agent of choice, or you may try it and see. Does it alter some of your cognitive or sharpness? Consider your risks and benefits. And maybe if you and your healthcare team agree, start a short trial of the agents. And by the way, you can buy it recreationally in a dispensary, even though you have a diagnosis. Try it out and see. You don't need to get a card. And then if you find it to be helpful, then you can invest in the medical card, because it's not terribly expensive, but it's not cheap. Do not bring it to the clinic or to the hospital. We accept Medicaid and Medicare funding, which are federal sources of funding. And so every healthcare agency I'm aware of does not allow cannabis on their premises because they don't want to be at risk to lose that federal funding. Again, think about your driving capacity. Think about kids in the home or your pets. Keep this locked up, just like you would lock up your opioids or your other controlled substances. And then here's what's just on the horizon. We're just learning in the past year, certain immunotherapies may have reduced blood levels when people are using cannabis products. So most oncologists are really concerned about the use of cannabis in people who are on an immunotherapy agent. So what are your goals of treatment? Think about your individual risk. For those of you that are working, does your employer require urine drug screens? This will show up. Even if you use it a few times a month, it stays in the system for a while. And so if that's something that your employer might be using, you might want to think carefully. As I mentioned, don't bring it to the hospital. Don't carry it across state lines because it is a federal offense. So I had a patient who was going to Iowa, got stopped for a traffic ticket, and got into deep trouble because it's not legal in Iowa. And then that whole issue of drugged driving. This I'm just sharing as an interesting case. This was a man who had a brain tumor, and he was taking this cannabis product, which is from a very reputable organization called Cresco. This is RSO, Richard Simmons oil. A lot of people with cancer are using this with the belief that it might help treat their cancer. This was the syringe that it was dispensed in, and unfortunately, the dose was inaccurately marked so that he was getting essentially 10 to 20 times the recommended therapeutic dose. He came to the emergency room with delirium, and initially they did a CT of the head, thinking, oh my God, is this cancer growing? And indeed, once they were able to do further investigation, it was this mislabeled cannabis. This is an interesting book. It's not written for professionals. It is written for the general public, and it's kind of amusing. So if you're interested in learning more.